Okay, so we're going to start our therapeutic case review. Just briefly, can everybody kind of introduce themselves? Our surgical panel. Andrea, please just start.
Sure. I'm Andrea Wolf. I'm one of the thoracic surgeons at Mount Sinai. I've been lucky to work with David and Claudia for several years. I'm also the director of the New York Mesothelioma program at Mount Sinai.
Hey, Seabird. I'm Seabird Harrison, also thoracic surgery at Weill Cornell and program director for our training fellowship director.
Paul Lee, thoracic surgeon at Northwell, and NASA taught me everything I know, so I appreciate that, and good to be here.
I'm Rob Headrick, a thoracic surgeon at Chattanooga, Tennessee, part of the University of Tennessee system.
I'm Nasser Altorki, thoracic surgery, Weill Cornell, and the fill-in on this panel.
Nasser was one of our trainees, by the way. So. Okay. This is going to be audience participation also. So everybody, okay. Case 1. This is the initial scan. You can see the little nodule in the left upper lobe, and you'll see it more clearly. 6 years later, this is what it looks like. 14 years later, that's what it looks like. And here they are. Over a span of 14 years, this is what's happened to it. It's gone from 3.5 to, 4.5 to 5.9 millimeters. And for those in radiology who really like this sort of thing, these had a doubling time of over 2,000 days. So that's really slow growth. This was actually stimulated from the conference in Madrid, where I showed a couple of similar cases, and I was surprised by the responses. So as you can see, this is really slow growing. So which feature most impacts decisions for taking action? Absolute change in size, independent of the amount of time, growth rate doubling time, morphologic features, cancer risk probability model. In other words, I'm really trying to drive at, the thing has gotten bigger, clearly, and it's going to keep getting bigger. So is it just that it's really growing, or is it the growth rate? What really matters to you? So it looks like doubling time is clearly important, or more important in this case, with a little bit of a tie with risk probability models and absolute change in size. Interestingly enough, at the Madrid conference, it seemed like it was more just the change in size that made the difference. So to our surgical panel, what's your thoughts about this case? How much do you think about change in size? Yeah, go ahead.
I'll start just in terms of, obviously it's a slow growing nodule, which is somewhat reassuring, but the morphologic features of it being solid and slow growing sort of factor in. I feel like there's more than one answer. And I'm realizing the audience had to pick A, B, C, or D. But it all comes down to cancer risk. And I look at a small nodule like this and I think about whether I want to take it out. And that would be intimately related to the cancer risk. I don't like taking out benign nodules that are tiny. And so I would also want to know a little bit more about whether there's any calcification in it, and whether there's some fat density in it. Things like hamartomas grow too, slowly like that.
Any other thoughts?
So I think growth maybe with the AI tool of looking at volumetric changes, things that may not be as apparent to our eyeball or take more growth for our eyeball to see it, is still the number one thing that causes us to pull a trigger. You could robotically navigate and get that answer really quick. Carcinoid tumors aren't going to take up PET. They can be really slow growing. They still will metastasize even in this kind of pathway. How much true risk to their life it impacts, you really got to put the patient in the center of that discussion, but persistent and continued growth now with ION or whatever robotic platform you'll do, I would easily go after it. We're also going to, instead of a measurement of millimeters, I'm probably going to have a volumetric assessment or some other tool that Mort or somebody else is going to come up with that helps us better define that growth and what it is.
I just want to echo that. What both so far have said. I mean, to me, this is like clearly in the realm of personalized medicine, and it's not just the radiographic features, but it's also the patient's features as well. You know, and that whole notion of the fallacy of sunk costs. Like, we've been watching this for over a decade, so therefore we should continue to watch it. But I think we all have those patients who every single time this scan comes around, they're not sleeping, they're freaking out, they're incredibly anxious. And so that would kind of push me towards, in this setting, being a little bit more aggressive with it. You have those other patients who just absolutely are fine following it, or fine getting their scans, are very reliable. So I think this is one of those interesting things where it's also taking into a lot of the patient factors along with it as well.
Yeah, so if this is the only reason you're getting those scans and you could prove this is a benign growth, and you just can quit scanning or that person, and cost-wise, it may turn out to be a better move than.
Well, let me, before I take any more comments, let me show you the next case because it closely relates to this one, and we'll get some other thoughts. Here's nodule on the initial scan. This patient, by the way, already had lung cancer and was treated. So he has this nodule. 8 years later, it's this. 14 years later, it's that. Okay. Now it's gone from 2 to 4 to 8 over a period of 14 years. Again, this is a long time. And the doubling time on this one is over 800 days. Now, if I were to ask my radiology colleagues in the audience, what is an 800-day doubling time? That really is benign. Anything over 400 is basically considered, you know, benign. Now you got an 800-day doubling time. So still really slow. So we can do this here, and then we're going to join the discussion. So on this case, which features most impacts decisions for taking action? Absolute change in size, growth rate, morphologic features? It's a risk probability model.
David, you kind of did something that Dan Kahneman would go nuts about in impacting their answers. You started priming people with certain statements, like 400
What?
day doubling time is the cutoff for a benign disease. You're sort of giving little psychologic primers that are affecting the decision-making of this
Well,
audience.
no, how, in which way? No, I'm curious, in which way do you think I'm priming the audience or the people?
Oh,
To use doubling time or not use doubling
This is a
time?
very similar, you're priming them to use doubling time in a way that you didn't for the first question. By giving the 400-day mark, this patient's doubling time is faster than the others,
It's faster, yeah.
but it's still well beyond the cutoff for what you guys would consider benign disease.
Right.
You didn't say that for the 2,000-day doubling time question.
I thought that was, I thought 2,000-day doubling time is pretty obvious. Maybe I didn't appreciate the audience.
But that's why people are, I think that is impacting the cancer risk terminology.
It's interesting. In the cancer risk probability model, you know, that got the highest, and that one I actually would have put as the lowest, because in general, the cancer risk probability models don't incorporate doubling times very well. Most of them are sort of based on a single time. But you're seeing, I was looking to see, mainly what I'm trying to get at here is, you have something that changes in size, and is it the absolute change in size that really counts for the surgeons, or is it the rate of growth that counts? And that's what I'm really driving at. Now, this one is clearly faster growing, but it's still awfully slow. Let me get the panel first. So Dr. Lee, do you want to comment on this?
I think you just have to have a informed discussion with the patient, and, you know, depends on the risk factor for surgery, the anxiety. I echo what other panels have said. You know, I think with the slow growth, if you allow comorbidity, I would personally leave them alone. And still, I mean, they're gonna die from something else rather than cancer. So, I think, you know, taking into consideration the patient's risk factors, anxiety level, is important. I mean, this is very peripheral lesion, it's easily wedgeable. And they're the ones, you know, you could do it, but also I look at morphology. To me, the second case morphologically is more suspicious than the first one. The first one looks more, you know, rounded appearance, maybe a hamartoma. So I do look at morphology of it, whether it's any speculations and obviously the patient's risk factors, you know, whether they're prior smokers, their age, et cetera, et cetera.
One of the scenarios we're setting ourselves up for is if we're telling that patient there's a nodule we're following, and I'm sitting there with them at a yearly interval or whatever that interval is, and I'm saying still there and it's slowly growing, and keep hearing that, there's a really hard psychological approach to getting them to keep believing on following it and accepting the logic that we're watching it and worried about it and it's growing, but we're not going to do anything about it. And some of the reasons we didn't is because that's a really hard spot to get to with a CT guided biopsy. Now with these newer platforms, it's a really, not the initial scan, but these later scans are really easy to get to with a robotic outpatient navigational biopsy. And we have different tools that may choose us to intervene sooner, but the patient psychology that we've drugged them through, there may have been some other reason they're getting the scans and that would have continued anyway. But I find it really hard to not put that in the decision because the patient's viewing it in a unique way that I'm worried and keep watching it, but I'm ignoring what's happening.
Yeah, and by the way, when we do these cases, when you look at it year to year, these slow growing ones, you don't see a change.
Right.
They'll say, did it change from last year? And the answer is no, I can't see a change. And sometimes from 2 years, you can't see a change. Wait 1 second, Fred. Dr. Altorki, can you weigh in on this topic a little bit? What your thoughts are?
Yeah, I think I agree with a lot of what's been said. I think, you know, the patient has a say in this that we should not ignore. Some people just can't live with that being there, especially the second patient. Having said that, I'm a fan of growth rate, and clearly for me, time here is not of the essence in any of these two cases. You can afford to watch them longer. But you know, the point you're trying to make is something that's slow growing, may not be cancer, which I agree with. But you know, when you go and invest with a firm, they tell you past performance does not guarantee future performance. And I feel that many of these cancers, you know, how many times have you gone back and seen that the cancer that you know is a cancer has been there for five years ago or 7 years ago or 8 years ago? So these things go through various rates of growth depending on what is happening locally within the tumor microenvironment and the accumulation of you know, genetic abnormalities within the tumor itself. And it may pick up speed at some point, but time here is not of the essence. So I would, personally, if the patient is okay, I would follow these for a while longer.
So the patient said to you, hey, listen, I'm pretty comfortable with this. You know, I'm 80 X years old. I don't, nobody would push for a biopsy at this point. You'd just be comfortable in either of these cases saying, sure, we'll keep following you. Come back in a year.
Yeah, I
Yeah,
think that's
everybody
reasonable.
would be. By the way, when we showed a similar case X months ago, we had a number of Chinese colleagues in the audience and the level of aggressiveness there to just, it's easy to take out,
He was
Take
out
it out.
14 years ago.
take it out.
Yeah.
Really interesting, different. Raja, you had a question or a comment, and then Fred.
So the other category I would add is not just cancer risk probability, but risk of that cancer killing the patient. So I've seen and followed tumors where you know this is an adenocarcinoma, you know, ground glass from 5 years. Theoretically, that's a cancer cure. So I'd want to know what's the risk of this cancer killing that patient. That's what makes me pull the trigger. Something like that, let's say 100% you're sure that's a cancer. Patient's 85. It's had that long doubling time. Do you really want to operate on it? Now, if you think, like Nasser said, it's going to pick up speed, then that's something that would make me pull the trigger. But it's not just cancer, yes, cancer, no. It's a cancer that's going to kill that patient.
And it's true. Occasionally we do see things pick up speed, but that's why I showed you 3 time points here. And the growth rate was persistent. Doubling time from time 1 to 2 was the same as it was from time 2 to time 3. So over the course of 14 years, it's basically stayed at that same growth rate.
And those-
So it's interesting. There seems to be a bit of a consensus here that shared decision-making or something akin to that is probably the most important thing in cases like this.
and
What's
those
great is we're
conversations-
now, sorry.
Sorry, this
We're now s-
conversations evolve. I mean, they evolve from year to year. To your point that it's
Okay.
hard to say we're concerned, but we're just sitting on it. But those conversations are nuanced, and every year it's a little bit like, this is reassuring. If it's not doing anything quickly, if we need to biopsy it, we can. If we need to remove it, we can. There's sort of a trust that builds.
So the conversation in my clinic setting prior to Claudia and David and LST trial was stage 4, stage 3. You know, now we're focusing on early small tumors and we don't know the answers to all of it. So critical thinking is part of that decision-making process with the patient. But this is the exciting part for this whole field.
Yeah.
5 years, 10 years from now, we're going to know how to answer that better.
I mean, Fred,
Except first mention of age was made by you, but the first thing I want to know is how old this patient is. If this patient is 50 years old, then those slow growing lesions could perfectly well, as Raja points out, even a slow growing adenocarcinoma can kill people if it gets to greater than 1 centimeter in size. And so what's the age of this patient?
both of these patients were now, I mean, we've been following, they were in the screening program. So they, for the most part, started 60 years old, and we've already been following them for 14 years. So they're at least 75, 80 years old at this point.
But what would the panel do if this patient was 55 years old? Patient 1 and patient 2.
Honestly, same thing in terms of watching, because I don't believe, maybe that first one's a carcinoid. I don't believe either of them are cancerous. If they were subsolid adenoids, I would look at it a little differently in a 50-year-old versus an 85-year-old. The subsolid adeno that Raj is describing in a 50-year-old, sooner or later, it's going to be an issue.
So in aortic valve disease, you know, we knew patients that needed to have something done, but the treatment was fairly involved with mortality associated with it. In these scenarios now where you're looking at it, you don't get a second chance at curing lung cancer. Rarely you do. So we know early intervention is key. So you can navigate to these lesions and biopsy them and even treat them in the same day, whether it's a surgical treatment or it's a local therapy with one of the many startup companies that are coming. There's a whole different world opening up that we may answer that question differently today than what we would have done 15 years ago.
So I think in this patient, I agree with you that if it's a patient younger, I would intend to remove it. I mean, I think it's the cost of doing CAT scans and obviously radiation risk. So if someone's 40, 50-year-old, I would steer them to taking it out. Because I think
Before biopsy?
before biopsy, because if your biopsy is negative, I mean, the false, negative rate for the small lesion like that, I would say probably 10, 20% at the least.
On the robotic approach, it's the most fascinating stuff, 97% diagnostic yield in a surgeon's hands.
Yeah, but if you have, but if the lesion's still growing, even though it's negative, would you leave it alone?
Okay,
would just
so
say-
so we've gone through
And
2
someone
cases.
Someone who's young, I mean, I would take it out.
I only have 12 cases and I'm now down to 9 minutes left. So I've beaten
right.
Dorit in terms of,
What was the answer?
no, we're still following these
Okay.
cases for now.
So that was,
Here's another one. This will come up in the panel in another session later regarding some of these non-solid nodules. Here's a non-solid nodule. This is the initial finding. By the way, this patient had a lung cancer already. In the opposite lung, you see the clips. Here it is a year later, so it's growing. And here it is a year earlier, there's virtually nothing to see. And so here they are. 1 year earlier to 1 year later. So clearly a growing non-solid nodule in a patient that's already had lung cancer.
Is this a female or and a smoker or non-smoker?
Let's play either way.
Okay,
Let's try it either way. I don't want to give too much, but I'm driving at, it's a growing non-solid. In a patient that is, the surgery, by the way, was 3 years earlier.
That's a vessel. That little part of it, you're saying it's entirely non-solid.
Yeah, it's just a vessel inside it.
What's the size? Is it 1 centimeter?
Oh,
less?
it's a little over a centimeter now. So would you perform an intervention at this point? Biopsy on initial finding, biopsy upon further growth, surgery on this, biopsy upon growth. So biopsy on the initial finding. Would you have waited till it grew? Would you do surgery on the initial finding, surgery upon growth, radiation upon growth, or just continue observing? And this will lead, by the way, into a later discussion where we're going to be talking about non-solids and what information we tell patients about them. Very important topic, I think.
You know, it would help if the report does not say something like a lesion on the spectrum of adenocarcinoma.
That's going to be, that's exactly the topic. That's going to be,
Immediately released into their record that they see before you
Yeah.
do
Yeah.
somehow.
this is the topic, that's going to be a whole discussion on that topic we're going to have. I think that's a really, so I wanted to show at least one case of that today before that talk. So this is the case. It's clearly growing. Recommendations in the screen, from the guideline organizations like I-ELCAP, who has protocols for how to follow this, and like LungRads that has protocols for following this. Ella didn't even look up when I said that. So, but our basic guidelines, if it continues to grow, it's less than 3 centimeters. In I-ELCAP, it doesn't matter the size. It's growing, it's completely non-solid, come back in a year. Now, this case, you might argue, is a little different because there wasn't a prior surgery on this one. But even if there wasn't a prior surgery, our probable recommendation on this, Claudia, what would you have said? Follow it. Our surgeons, what do you guys say?
so if this was a previous cancer adenocarcinoma,
Yes.
particularly a female non-smoker, this is a well-differentiated adenocarcinoma. What we have now is data that says if in isolation, you could wait till 3 centimeters if it's pure ground glass. But in this scenario, I would biopsy it and send off for an EGFR mutation, and they're likely to have that. And the survival data in the last year coming from that, they're probably developing multifocal disease, and it's important to get them on that treatment. As opposed to if it's the only lesion, they never had cancer before, I would probably keep watching it until it started becoming semi-solid.
Other panelists, what do you think?
I would follow it.
I would follow it. My concern with this person is that they are likely to have multiple lesions and they do come as new, because you're saying at the time of surgery, that wasn't there at all. So there will be other lesions and one of them may be more aggressive. And so doing anything to this person may alter what you can do in the future to this person.
But you could skip the biopsy or the surgery and just look for circulating EGFR through a liquid biopsy, but getting them on Tagrisso, one of those medications, if they have, it's key to their survival.
But I'm not sure here it's going to change what you're going to do for her, though. I mean, if you biopsy it, let's say it comes back adenocarcinoma in situ, and are you going to take it out?
No, if she had an EGFR mutation, you wouldn't take it out at all. You just put her on the drug.
You would treat
Yeah,
her
and for life now. It used to be 2
with a
years.
single lesion like that, you would treat her
Yeah.
with? I would not.
For a single lesion, they're putting them on TKI.
But she's not a single lesion. She's got a previous adenocarcinoma, and we're assuming it's a female non-smoker. At
Yeah,
least
but
that's what-
right now it's only one lesion.
but it grew pretty quickly.
But I don't think it's indicated to treat it with
Are-
targeted therapy.
We're all surgeons. Are there medical oncologists in the room who can comment on whether this patient's a candidate for DKI?
Thank you, Melissa, my medical oncologist. I think I would agree with you because if the first lesion is an EGFR mutated and it's a recurrence and it's a systematic disease, then there is indication for systematic treatment.
But
We can discuss.
In the
that.
last
Wow.
ASCO meeting, there's strong.
You
data.
just woke up the oncologists in the audience. You just woke them up.
I think it's very much depending on the previous cancer history. But let's play the game that he has the EGFR from before. and come up with this lesion here, certainly I would look very carefully for other lesions. Point two, I would have a biopsy. If the patient has an EGFR mutation here, then we need to have a serious discussion whether systemic therapy or removing this one, if this one is the only one. I don't think there is, he will have recurrence, but he will have a recurrence in stage 1A, but most likely disseminated disease, in my opinion, from a biological point of view. So it is difficult decision to make, but
I completely disagree. Right? I'm sorry. I mean, I have thousands of Asian women that I'm following with these GGOs and nothing happens. And this is a patient with probably a synchronous lesion as a field defect. And I can't imagine treating every single one with targeted therapy. And I have patients to follow years and years. I'm sure Nasser, all the surgeons have, and we just follow them. So to start a targeted therapy on one lesion that's slowly progressing, I disagree.
Yeah.
That's-
Let's look at the, Nasser, you want to say,
Sorry.
were you saying something just now? Good.
No, I wouldn't. I think that just that it's like Tagrisso is an intervention. So if we're going down the intervention path, then this patient is much better off with a resection, if possible, than getting her on a drug that you don't know what it would do in this situation. And how long would you keep her on the drug? And it's not without adverse events. I mean, it's not nothing. So I would.
and the EGFR TKI is not
I think-
approved for stage 1A, 1A either.
No, it's
So
not.
if this is
Yeah.
the only lesion, I agree with you, Nazir.
Yeah.
But we're putting it in context of there was another cancer already
This,
prior to that. We don't have
Yeah.
all the details on it, but
Yes.
I.
So,
But-
So-
these are complex cases and you, first of all, you have to go back and do the molecular profiling on both lesions if you choose to go that way, if you're going to biopsy or do something. Again, I think continuing to follow this patient is what I think would be the right approach. But if you chose to be more aggressive, you have to do that molecular profiling on both. And believe it or not, you still could have two very different EGFR mutations if you had them, all right? But it still doesn't mean that they should be put on a TKI either. So I think, Nasser, you made some really good points. Remember, how long do you do it? There are toxicity, costs a lot of money. So I think we do have to be careful and give the patient the benefit of the doubt here. And I think continuing to follow that patient would be the right approach.
And if you must make a determination, which you don't have to, but this is, to me, it's an independent primary lesion. It's arising in a non-solid nodule. So I mean, there is no question of a metastatic lesion here.
Exactly.
So let's look at this next case because it's related. Here's a person, there was a solid lesion. It was very slow growing, but it was growing and we resected it. And it was an adenocarcinoma. At the time of surgery, focus on the right lower lobe. There's really nothing there. 3 years post-surgery, we have this. 4 years post-surgery, really no change or no
It
perceptible
looks
change.
better. Why didn't you say that?
read more deeply.
No perceptible change. So what do we do with this one? It's similar, but now, you know, it's a
Very
little
similar case.
biopsy on the initial finding, biopsy on growth. Continue observing. This one, you know, this one moved quicker, at least. Continue observing. So we got a surgery on growth. We got wonderful. Okay, so it seems that people are pretty comfortable following these. Okay, let me move on to see if we can show something else.
Different type of case now.
Well, this is a little bit different. So here's nodule, solid nodule in the left upper lobe. And if you look really carefully, you can see some very faint stuff in that left upper lobe at the same time. Okay? What was done with this person? what type of initial intervention would you do? Wedge, lobectomy, multiple wedges, biopsy non-solid, then decide.
I'm sorry,
Wait,
there's a solid nodule and the others are within the
Same lobe, left upper lobe had that solid nodule, and there was just some very faint stuff also in the left upper lobe as well. So half and half.
I think, David, it really depends on the risk for the patient, right? I mean, what the pulmonary performance status is like, pulmonary reserve, with the patient tired lobectomy, what's the age, comorbidity. So if this patient's, got a lot of comorbidity, I would just do a limited resection on the peripheral PET positive lesion, watch the other one. If the patient's a young patient, good risk, you can have a discussion and maybe, do a lobectomy. So I think you have to individualize, for the patient's comorbidities.
And the other non-solids on the other side.
So here's what happened. 3 years later, it got a little bigger.
So you did a wedge here.
So they did a wedge. Wedge was done.
Mm.
And you can see the two other lesions, they're a little more prominent at 3 years later, and we elected to follow. Virtually no change 5 years later. So everybody's feeling, I think, pretty good about this case. But this is a time when it's getting really, I'm just showing this as an example. This is the same person. When you look really here, on the left is a 3 millimeter slice thickness. On the right is a 0.2 millimeter slice thickness. So now we're having these super duper scanners with thinner slices. And I'm telling you, we are seeing, when you start looking, we're seeing non-solid nodules everywhere. And so we're going to have to really start rethinking what we do with it. I mean, this is that same person. So there's at least 2 non-solids. They seem to have gotten a little bigger. They kind of stopped growing. But when I look more carefully, and there were more of these, when I use the thinner sections, they're all over the place. And they're in the other lung too.
So
They're
what was
all
the
over. So
nodule
we're
that was wedged out? What did it do?
adenocarcinoma.
So
adeno-
invasive adenocarcinoma.
Yeah, invasive adeno. So that was it. I'm going to stop. I'm well over time. I got through 5 of my 12 cases. But I thank you, because for the next conference, I don't have to do any work. I'm ready. I'll just show the next 6.
Well, this
Thank you,
shows-
panelists.
It shows hope, because we don't have the answers, but we're focusing on more meaningful things in late stage 1 cancer, and that's the exciting part.